I'm here with Ahmad Aref. You're giving an interesting session dealing with a comparison between ALT and SLT. Can I get you to sort of flesh that out?
Yes, yeah. Thank you, Josh. Well, I think that we've got an effective procedure with laser trabeculoplasty, and we have two modalities of administrating the laser treatment. We can use argon laser energy, as with ALT, or we can use a Q-switched ND-YAG laser system to administer the energy, as with SLT. And both treatments have been around a while now, and so the topic of our session is going to be, which of these treatment modalities, if any, has an edge over the other.
Let me ask you this. I've done both. I don't in my own practice. I don't do argon treatment that much now. From a clinician standpoint, performing the two procedures is very similar. Not exactly the same, but it's very, very similar. Do the two procedures work the same way physiologically?
Yeah, that's an excellent question, and I think there's still many unknowns with regards to mechanism of action of either procedure. Initially, it was thought that the mechanism of action of argon laser trabeculoplasty was that it caused physical scarring within the trabecular meshwork, widening adjacent trabecular pores and allowing for enhanced aqueous outflow. More and more, we're learning that that's probably not the case for either ALT or SLT, and it's probably more likely some kind of biochemical cascade of events that's set forward after administration of the laser energy, with macrophage recruitment to the trabecular meshwork, remodeling of the trabecular meshwork, and enhanced aqueous outflow at a biochemical rather than a grossly mechanical level.
Is some a cytokine liberation too, right? Because
exactly.
One of the things that I've seen, and I'm sure we've all seen, is that you'll treat the right eye, you'll get a substantial pressure drop in the right eye, but you get a little pressure drop in the left eye too.
That's exactly right, and there's been some studies to support that, and we are seeing what appears to be responses in the fellow untreated eye, and cytokine release and a biochemical cascade of events would explain that.
Now, with argon treatment, whether scarring is a mechanism of action or a byproduct of treatment, certainly that scarring limits the number of times that an angle can be treated. What about the case with SLT? Are there limits? Can I retreat my patient ad infinitum?
Yeah, well, that's another great point. And we do induce mechanical effects on anterior chamber angle structures with ALT, and we don't induce the same mechanical effects with SLT, and that's been shown with histologic study in cadaver eyes. And that led to folks postulating that SLT may be a repeatable procedure, and in fact, that's been supported by clinical studies which have demonstrated continuing success with retreatment sessions with SLT, up to 4 retreatment sessions after the initial session. And unfortunately, in studies that have looked at ALT retreatment, that same degree of success has not been borne out. So yes, SLT appears to be a repeatable procedure, whereas intraocular pressure lowering associated with repeat ALT is much, much less likely.
Are the two procedures comparable in terms of their effect that they have on pressure?
Yes. And I think the most powerful data we have in that regard comes from a randomized control trial done in Canada, where eyes were randomized to either ALT or SLT and followed over a 5-year period. And over a 5-year period, both treatment modalities demonstrated intraocular pressure lowering efficacy, but to a similar degree. So in terms of efficacy, there does not appear to be a difference between the two treatment modalities.
In your clinical practice, now sort of shifting gears, what do you do? Do you ever do argon laser treatments?
I typically will prefer selective laser trabeculoplasty. And given the similarity in efficacy, and there's even now a similarity in safety, I prefer selective laser trabeculoplasty for a few reasons. The first is that we know that although laser trabeculoplasty is initially successful, the effect of our laser treatment wanes over time with a median survival time of about 2 years. So we know that when we administer the laser treatment, that effect will wane over time, and it's advantageous, I think, to have a modality which allows us to retreat once we start losing that effect. And we can do that with SLT, but much less likely to get that effect with ALT. So that's the first reason. The second reason is, as I mentioned, there's mechanical effects on the angle that are induced by ALT. And there's no real major clinical consequence that we know of as of today for why that would be an issue. But my concern is that with a host of new innovative devices designed for insertion into Schlemm's canal, we may face some challenges in patients that have been treated with ALT. So I feel much more comfortable treating patients with SLT knowing that I'm not inducing any scarring of their angle. And in the future, if that patient goes on to require an intracanalicular stent of any kind, I feel much more comfortable that I'm not disrupting their anatomy.
Interesting stuff. Interesting stuff.
Yeah.
Ahmad, thank you very, very much for spending time with us today.
Thank you, Josh. Thank you.